Hello, I'm Diesen. I'm one of the pediatric surgeons at UT Southwestern in Dallas. And to slightly pivot on the topic, I'm going to talk about complex abdominal wall defects and what are they and what are their long-term implications. So if you get a patient that has a gastroschisis or an omphalocele, what does that mean for you when they come to your office and they're 30 or 40 years old? What have we done and what are some of the complex complications that they have later on. Whoop. There we go. I have no disclosures. So the abdominal wall defects that I'm going to concentrate on are gastroschisis and omphalocele. There's also a hernia of the umbilical cord, which is a variant of omphalocele without the concomitant comorbidities and with a smaller abdominal wall defect. And just showing the difference between that and a typical umbilical hernia. So gastroschisis is characterized by infants being born with their intestines eviscerated. They're usually smaller than omphaloceles, usually less than 4 centimeters, just to the right of the umbilicus, and they can be characterized by this fibrinous peel that you can see in the right lower quadrant, which makes it difficult to identify if they have a complicated gastroschisis, meaning one that's associated with an atresia. So intestinal atresia is the most common associated anomaly with gastroschisis. About 15% of patients with gastroschisis will have this. Oftentimes we can't identify it initially, so we reduce the gastroschisis, and then if they haven't opened up in about 6 weeks, then we do a small bowel follow-through to look for an obstructive process. And if so, those 15% often will require or do require a second operation in order to repair. It can also be associated, though, with perforation, necrosis, and volvulus. And those are the patients that require multiple operations and are more at risk for abdominal hernias going forward. Overall, these patients do quite well and have a 90% survival. And it seems to be more environmental factors as opposed to genetic factors that predispose to gastroschisis. It's assumed that it's a decrease in the omphomesenteric blood supply by a perhaps ischemic event. It's known to be associated with cocaine ingestion, methamphetamines, THC, poor maternal nutrition, and decreased maternal age. There are also other theories, but of course we don't know for sure. As opposed to omphalocele, so omphalocele, we have a defect in the abdominal wall and the abdominal wall musculature. And the thought here is that it's actually a failure of the body folds to complete their journey from lateral to medial. Now, if you have a cephalad fold defect, you're also going to have likely a pentalogy of Cantrell, in which you actually have part of the sternum that's missing. The heart will be involved in this defect. You'll also have CD8, congenital diaphragmatic hernia. If it's just the lateral folds, you'll have the typical omphalocele pictured here. If it involves the caudal fold, you will also have a cloacal exstrophy or a bladder exstrophy as well. Those are some of the concomitant conditions that can make these patients quite complex. Omphalocele is also unfortunately associated with lots of other anomalies, trisomies, GI, GU, and cardiovascular anomalies. This is where the morbidity really comes from these patients. It's associated, and here's one of our more severe abdominal wall defects. So this involves an ectopic cordis, so the heart's involved in this defect. You have the giant omphalocele, so anything over 4 to 5 centimeters is considered giant, as well as a bladder exstrophy and cloaca. And so these, while the abdominal wall defect is a significant concern, the underlying other structural anomalies are what needs to be assessed and whether or not these patients should be provided with a more palliative option. So for operative repair at birth, we either initially close them suturelessly or primarily, which I'll discuss in a moment. If we can't get everything in, we'll put in a silo, and then we can do either a sutureless closure or operative closure. Occasionally, we use biologic mesh if we just need to keep everything in, if it won't stay in on its own with a sutureless cover. And only about 1% require a long-term complex abdominal wall reconstruction, like a component separation, tissue expanders, or muscle flaps. And tissue expanders are probably the most well described in our pediatric literature, but realize our pediatric literature, our largest study, has 7 patients. So sutureless closure is what we're doing mostly now. And we're able to, without taking the patient to the operating room and often without intubating them, we're able to reduce the intestines, take a piece of the umbilical cord, place it over the opening, and put a dressing on it. And that dressing can be just about anything. It could be a tegaderm, it could be a duoderm, it could be Mepalex. And then you just allow epithelialization to occur. Now, an umbilical hernia often happens. And so almost all of the patients will have an umbilical hernia at about 6 months of age. But over the last 10 to 15 years, we found that a lot of those umbilical hernias will resolve on their own. So depending on the long-term follow-up of the studies and the age of the patients in these studies, they found that you can have umbilical hernia resolution of somewhere between 70 and 90% if you wait out till 5 years. And so this was one of the first studies that looked at that in a multi-system approach across 10 different centers, and found that, that somewhere between 25 and 32% of patients had an unresolved or unrepaired umbilical abdominal wall hernia at the time of the follow-up of this study. But significantly, that 34 to 50% had resolution. Now, if you look at the time of the umbilical hernia repair in these patients, it tended to be, this is in months, realize pediatric surgery, so 8 months versus 20 months. Oftentimes, we don't repair umbilical hernias in kids until they're school age, so about 5 years of age. So as more and more studies have allowed children to resolve these abdominal wall defects on their own, the number of patients that end up requiring a abdominal wall hernia repair at age 5 ends up only being about 5%, which is pretty amazing. It means that we don't necessarily need to do anything. This doesn't end up being a activity limiting condition in these children. And if they still have something present by the age of 5, then we can intervene. So our silo reduction, so oftentimes you can't necessarily reduce all of the bowel initially, and so we'll put them in a silo, gradually reduce them. And then if you can either, after that, do a sutureless repair, again, just placing a dressing over top of it, allow it to epithelialize, or you can take them to the OR and do a primary repair. Realizing with omphalocele in particular, the liver is often adherent to the sac on the omphalocele, and so you don't want to take that off. Often that would be associated with significant bleeding. And so this is what a primary repair looks like in infancy. So it's hard to detect necessarily when they're older because all they have is the scar at their umbilicus. Some of these complicated gastroschisis, though, unfortunately can have significant comorbidities if there's bowel strangulated at the time of birth. So this is an example of a vanishing, it's called vanishing gastroschisis, in which a substantial amount of the bowel was actually made ischemic by the defect itself closing and being so tight. And other times you just have to pay close attention to the umbilicus itself. Let's see if I have a pointer. So this little nubbin can be easy to miss when the baby is first born, but that's the sign that that patient actually needs an operative exploration because they were actually missing a substantial amount of bowel. Now they have an atresia because of gastroschisis that closed too tightly. Now, these giant defects, those are the ones that are more complex that we end up talking about. And now for an omphalocele specifically, so it has that sac over top of it, we tend to do a paint and wait. So we want that to epithelialize with either, by dressing it with either sylvadine or betadine, allowing it to mature and slowly pushing it back in. We have OT come and provide support devices for the family and the patient, teach the family about wound care, and allow these children to grow for years. The children grow, their abdominal wall musculature develops, and the size of the defect itself does not enlarge, but their abdominal wall musculature does. And then once they're bigger, we decide what sort of repair they need. Oftentimes, these children are their tissues are otherwise healthy. They're not smoking. They don't tend to be obese. And so tissue expanders and flaps are our mainstay. Now, this is a picture of it epithelializing slowly over time. The OT support while it's epithelializing. And this is a case where we actually did mesh repair. Now, long term, we know that these patients over time have chronic GI complaints, or can have chronic GI complaints. And this is focused on omphalocele in particular. Whether this can be small bowel obstructions, just generalized abdominal pain, blind loop. About 10% of these patients will require repeated hospitalizations, and up to 30% will have a repeat abdominal surgery. Most commonly, though, it can be from small bowel obstruction, it can be from hernia, and later on in life tends to be cosmetic surgery for scar revision. These families do report, these patients as they get older in their teen years and 20s, report stress. They report, yes, stress from having no umbilicus or from their abdominal scar. 10% will report that they've had teasing, and so oftentimes will seek cosmetic modification. So when we're looking at what sort of surgeries do these patients need overall, so this is one of our longer-term studies. We have 2 studies that have looked at these patients long-term, and long-term for us is 9 years. So again, they're not even adults yet. But we know that they can need repeat abdominal surgeries for small bowel obstructions, for hernias, and scar revision being the most common. Now, we also have the patients that have more significant severe abdominal wall defects later on in childhood and early adulthood. And so these are the ones who have a significant abdominal wall defect and have loss of abdominal domain. And so in describing these patients, there's no randomized study looking at the various approaches. The most common approaches described include either simple approximation of the rectus abdominis fascia, depending on the size of the defect, plus or minus the use of submuscular tissue expanders. Rectus abdominis sheath turnover flaps are also commonly described, as well as mesh repair or mesh reinforcement in these patients, or some combination of the above. So here's some pictures of some of the more complex. So this actually has, here we go. There's actually tissue expanders here and here. And then this was reapproximated using a rectus abdominal sheath turnover flap. And we usually here we go. And we involve our plastic surgeons in these reconstructions. And so these patients, I don't know if I can go back. So this patient here was a teenager and had relatively large abdominal loss of domain, but actually with mobilization and a rectus abdominis sheath turnover flap was able to have reapproximation. In this case, they did not use mesh. This case over here, you can obviously see the tissue expanders right here. The other thing that predisposes patients to a more significant abdominal wall defect, not surprisingly, just like adults, are those who've had intercutaneous fistulas and other complications once healing from their gastroschisis. Component separation is also occasionally described in the literature. Again, we're talking about case report or case series of this series, for example, had 3. So it's reported, though there's not great data as far as long-term outcomes. Abdominoplasty. So of the things that are reported most frequently with patients are complaints about their scar. And this can be complaints about pain from their scar. Up to 20% will report chronic or intermittent pain from their scar and want revision of their scar, or cosmetic concerns regarding the scar. And this is reported even more so than the abdominal wall hernia defects themselves. I did want to mention umbilical cord hernias, just because it looks like an omphalocele. It's covered by a membrane, but it involves just the umbilical. It's the abdominal intestines that are basically eviscerated just into the cord itself. The actual abdominal wall defect is actually quite small. Now, the great thing about these is if the intestines aren't stuck to or aren't adhesed into the cord, which oftentimes they're not, you can just go up, reduce it, and then put a clamp on. So this is just after I reduced one of them. And you just put a clamp on and you need to do nothing. If the actual intestine has an adhesion inside the cord, then obviously we have to go to the OR and release that adhesion, drop it back in, and they have a small umbilical hernia right afterwards. Looks great. So in summary, these are the most common severe abdominal wall defects in children and how we repair them as children, and some of the consequences that you may see in your clinic as children inevitably become adults. If you have any other questions about pediatric surgery, I'm happy to talk at length, but thought this was the most relevant for the SAGES audience.
Thank you.